Hello everyone, welcome to another video on arterial blood gas analysis. In this video we will see some basic aspects of ABG analysis and some basic things about arterial sampling. So the first question is, when do we do ABG analysis? So as you can see here, when patient presents to us with sudden dyspnea, cyanosis, abnormal breath sounds, sudden unexplained tachypnea, use of accessory muscles, when we are performing CPR on cardiac arrest patients. So basically, in all these indications, we are checking adequacy of ventilation in patient, whether the patient is removing carbon dioxide at a normal rate or not, whether the carbon dioxide is being accumulated in the body or it is excreted at a higher rate than normal. To change ventilatory settings in those patients who are on ventilator machine, it can be BiPAP, non-invasive ventilation, or it can be invasive ventilation. Nowadays, this is a very major indication of doing APG analysis because of COVID. There are progressively increase in number of patients in ICU setup and to monitor severity and progression of disease. Now coming to contraindications, these are not contraindications of ABG analysis. These are basically contraindication of arterial sampling. So abnormal modified Allen's test. We will come back to this test. What is Allen's test? Local infection at puncture site, patient with AV fistulas and vascular grafts, peripheral vascular disease. It can be Raynaud's disease or it can be atherosclerotic disease of limb and coagulopathy. Now another contraindication is patient on anticoagulant therapy like heparin or low molecular weight heparin. But if we see COVID patients in ICU, almost every patient is started on enoxaparin, which is a low molecular weight heparin, or on heparin if patient is in renal failure. So nowadays, this is not considered a contraindication because we cannot skip the ABG analysis in a patient who is on a ventilator. So we have to take some special precautions, like we have to apply firm pressure on arterial puncture site for minimum 5 to 10 minutes. And as we all know, in COVID ICUs, the relatives of patients are not allowed inside the ICU, and the patient is usually, if he or she is on mechanical ventilation, they will not be in cooperative state or conscious state. So it will be our duty to personally stay there for 5 to 10 minutes and apply firm pressure on the arterial puncture site, or else there will be a big hematoma. I have seen many cases when we have taken sample from femoral artery for ABG analysis, and then the next day there is such a big hematoma on the thigh that we have to send surgical reference for the patient. So then it becomes our duty. Now coming back to point, what are the sites of arterial puncture? So the most ideal and preferable site is radial artery. So for to check radial artery patency, or rather to check ulnar artery patency, we do modified Allen's test. Now what is Allen's test? So as you can see here, this is modified Allen's test to check the overall blood supply to the hand. On the lateral aspect of the arm, here we have radial artery, and on the medial aspect of the arm, we have ulnar artery, forearm, sorry. So first step is locate the ulnar and radial arteries and have the patient make a tight fist for about 30 seconds. Now uh, ask patient to keep making a tight fist, and we have to obstruct both radial and ulnar artery. As you can see here, we have obstructed both radial and ulnar artery. Now we ask the patient to open the palm. So because we have obstructed both radial and ulnar arteries, the palm will be pale. So the palm should blanch. If it doesn't, you are not applying enough pressure. So start again. Now what is positive modified Allen's test? When we release the pressure on ulnar artery, here is ulnar artery. When we release the pressure from ulnar artery, the hand flushes within 5 to 15 seconds. We take upper limit as 15 seconds. This means that the collateral circulation from ulnar artery to the hand is normal because the hand flushes, so the blood is coming from ulnar artery. In negative modified Allen's test, the hand flushes after 15 seconds. So it takes longer time than usual. This indicates that collateral circulation by ulnar artery is not adequate. So in negative modified Allen's test, if we puncture radial artery here and As we all know, whenever we puncture an artery or vein, it carries very high risk of thrombosis in that particular artery or vein. So in that case, if a thrombus formation occurs in radial artery, then the blood supply to the hand will be compromised. So in case of negative modified Allen's test, we have to choose alternate site for puncture. In positive modified Allen's test, we can go ahead with the same side radial artery sampling. How to remember this? I have remembered this as positive puncture, because many of time we get confused between what is meant by positive and what is meant by negative. We have to just remember like this: positive test, you puncture that artery. As you can see here, this is the site of radial artery. This is ulnar artery. The patient has clenched his or her fist, and we have occluded both arteries. Opening By opening the fist, we can see that the hand is pale, and when we release the pressure on ulnar artery, there is flushing of the hand. So this is positive Allen's test. Now, suppose if Allen's test is negative, or there is a cast applied on patient's site of sampling. So what can be the alternate routes? The alternately we can take sample from brachial artery or femoral artery. We prefer femoral artery because it is very easy to locate and take sample from femoral artery. But when we are taking sample from femoral artery, particularly for ABG analysis, we can confuse it with femoral vein, and by mistake we can also take venous sample, because as we all know the anatomy, that femoral vein is just situated medially to the femoral artery. One more thing I would like to say here, whenever we are working as interns in wards or ICU, we are asked to do routine sampling of patients, and in ICU patients, the sample has been taken so many times that the whole arm and every possible site of peripheral vein is swollen, and we are not able to find the vein for sampling. So in those cases, we used to just go for कि नहीं मिल रही है vein, कोई नहीं femoral sample ले लो. So whenever we are substituting femoral sampling for peripheral venous sampling, we always have to go for femoral venous sampling. We have to take care not to puncture femoral artery just for routine, CBC or renal function test or liver function test. So how do we locate femoral artery? This is patient's ASIS, and this is patient's pubic tubercle, and this is pubic symphysis. So here we have inguinal ligament, as we all know, and a point between pubic symphysis and ASIS in the middle. This point is known as mid-inguinal point. Now just beneath this mid-inguinal point, the femoral artery enters into thigh region, and just medial to this artery we have femoral vein. So, and on local examination, we will find inguinal crease like this. So, the inguinal crease does not exactly correlate with inguinal ligament. It lies slightly below the level of inguinal ligament. So, whenever we are locating femoral artery or femoral vein, we have to first palpate the inguinal crease, and then we have to go approximately one finger breadth below the inguinal crease at this point. That is approximately 1 to 1.5 centimeter. For femoral artery, if we are planning to puncture femoral vein, then we have to further go medially to this point, like 1 to 1.5 centimeter, that is approximately one finger breadth medial to the femoral artery, and we can easily palpate the femoral pulses at this point. Now coming back to arterial sampling, this is ABG needle and syringe. So this is routinely used in ICU setup. We have to keep in mind that this is not heparin coated syringe. So we have to first coat this syringe by heparin, as heparin is anticoagulant used in arterial blood gas analysis. So how do we do that? We have to just fill the heparin in this syringe till 3 ml mark, and we have to flush the heparin out. As you can see here, we have to expel the heparin through the needle. By doing this, there will be some amount of heparin which will be coated on these walls of syringe. Now, how much heparin is needed? Okay, 0.05 to zero point 0.1 ml of heparin per ml of blood. This much amount of heparin is needed. So as we all know that this is very minute amount. So just by flushing the heparin through the needle, the whatever the heparin is sticking to the syringe wall, it will be enough. So in one sample we take usually 2 to 3 ml of blood. So in total, zero point 0.1 to zero point 0.2 ml of heparin is used in sample. Now, what if there is increased heparin in sample? We did not flush the syringe properly, and there is more than this much amount of heparin in syringe. Then we all know that pH of heparin is 7. The pH of our normal blood is 7.4. So compared to normal blood, this pH is acidic. So there will be false decrease in PCO2 levels and false decrease in bicarbonate levels. And we can see here that this is airtight seal for ABG syringe because we have to prevent air bubbles from entering the syringe. Now, what if air bubbles are present in the syringe? It is very easy, right? There will be false increase in PO2 levels of arterial blood. Now, how to take the arterial sample? So here are photographs of steps. Before this, we have to keep the tray ready. We have to take consent of the patient or patient's relative. We have to tell the patient that this will be a little bit more painful than normal peripheral venous sampling because we are puncturing deep for the artery. Then we have to heparinize the syringe. So this is done by doing expelling the heparin through the needle. Then first we have to locate the radial artery or any other artery, whichever artery we are puncturing. Then we have to locate radial artery and feel the pulsations of artery. Then we have to insert the needle at 45 degree. Now look at the position of wrist here. It is extended. We can also put a small 100 ml pint below the wrist of the patient to extend the hand. And the most important thing for arterial sampling is we have to observe the flashback carefully. If we see here, the doctor here, he or she is not pulling the plunger. In peripheral venous sampling, we confirm that the needle is in the vein when a blood appears around the hub, and then we pull the plunger. But whenever we are piercing the artery, the pressure in artery is great that we do not have to pull the plunger. If we have to pull the plunger, then we suspect that we are not in artery, our needle is in vein. As you can see here, we allow the syringe to self-refill, and after 2 or 3 ml of blood is taken, we remove the needle and apply immediate firm pressure. Now, this is very important step for the patient to apply firm pressure to prevent hematoma formation. Then we engage needle safety guard. We remove the needle and we attach cap to ABG syringe and label sample. This is the whole procedure. Then we discard the sharp in white box, and that we all know about biomedical waste management. Now, what then? We have to transport the sample in cold chain. Now, there is another jugaad, I would say. What if this ABG syringe is not available? Then we can take any normal 2 or 5 ml syringe and we then do not remove the needle. We just insert this needle into rubber cap of vial of any drug or even urine collection container, anything like that. When we insert this remove needle into a rubber vial, we create a kind of airlock to prevent bubbles entering into the syringe. But this is very unreliable method, and this should be applied in emergency cases. Ideally, we should go and get this ABG syringe from ICU or medicine ward, something like that. So this is about how to take arterial sampling. After this, there will be ABG report in our hand. So it will look something like this. So as you can see here, the pH is shown, PCO2 is shown, PO2 is shown. But if we take a closer look here, the carbon dioxide is calculated. So this is just a sample report, but if you see any report, sorry, bicarbonate levels, the bicarbonate will be calculated. It is not measured directly from the arterial blood, and other electrolytes are also measured. So after we have this report in our hand, we have to confirm the arterial nature of blood. Now, how do we do this? There are two methods. First is uh, we compare PaO2 and SpO2. What is PaO2? That is arterial oxygen given in the report. And what is SpO2? SpO2 is the saturation of oxygen we measure at the time of presentation by pulse ox. So as we all know that uh, pulse ox measures arterial SpO2 only. It does not measure venous SpO2. So when the difference between PaO2 and SpO2 at the time of sampling, this SpO2 at the time of sampling, if this difference is within 2%, then it is okay. If this difference is more than plus minus 2%, then we can say that there is some error. It can be sampling error on our side, that we have take venous blood and send it for the examination, or it can be a laboratory error. We have to repeat the ABGA. Another method is we check bicarbonate levels. As we saw here, the bicarbonate levels are not directly measured from arterial blood. It is calculated based on Henderson-Hasselbalch equation by indirect method. So we check bicarbonate concentration on same sample. If they both are correlating, then we can confidently say that yes, the arterial nature of the sample is confirmed. And we can also calculate bicarbonate. Now, how do we calculate bicarbonate? So bicarbonate is 24 into PCO2 upon concentration of hydrogen ion. So PCO2 we get by this, and hydrogen ion is also calculated in electrolytes of ABG report. And for reference, in normal person, we saw that PCO2 is 40 millimeter of mercury. At pH 7.4, the bicarb concentration is also hydrogen concentration is also 40 milliequivalents per liter. So in normal person, bicarbonate concentration will come to 24 milliequivalents per liter, which is in normal value. So just before ending this video, let us revise normal values of various parameters. What is the normal value of pH? What is the normal value of bicarb concentration? And what is the normal value of PCO2? So pH is between 7.35 to 7.45, average being 7.4. Bicarb is between 22 to 26 milliequivalents per liter, average being 24, and PCO2 is between 35 to 45 millimeters of mercury, average being 40 millimeters of mercury. So these are some basic aspects about ABG analysis. In next videos, we will discuss abnormalities of ABG parameters like metabolic and respiratory acidosis and alkalosis. Thank you so much.